This is Pain Management, Chapter 30. A lot of learning objectives in this chapter. What it comes down to, though, is how do we recognize pain in small animals or large animals, and how do we communicate that this animal is in pain in a validating way so that our doctors will work with us to provide the best care for this animal. And in order to communicate that, you need to understand it. I'm going to talk about a couple of different types of drugs as well, nonsteroidal anti-inflammatories, local anesthetics, opioids, and alpha-2 agonists. These are all ways in which we can create a pain-free environment for these pets. It starts by being the patient's advocate. You first need to be able to understand what pain looks like in animals. I have some examples for you from the Colorado State University, both a canine pain scale and a feline pain scale. These are located at the end of your chapters. You can also find these charts online. It's important to practice with these, understanding what the animal might look like as they're exhibiting pain, what their psychological and behavioral attitude will be, how they will respond to palpation, and also what their body tension will be. You should be able to go through this and mark using your own animal or in a clinic for each pet what you're seeing exactly. Now, you're going to see sometimes that we have marks throughout this chart, but you're going to go with a one and put them at the level where you think the average is. I would argue that if we know that we're going to create a painful procedure, we're going to start our pain relief here. This animal is comfortable when resting, they're happy, content, they're not bothering their wound or surgery site, and they're interested or curious in their surroundings. We want to start our pain relief here. If we're to this point where the animal is constantly groaning or screaming when they're unattended, we have waited too long. So I want to argue that you should know what these signs are and understand when you need to step in. Especially with cats. They're not going to show this type of behavior until they are really sick or really hurting. So that's what we need to do. We need to be able to communicate what we are seeing on that pain scale. We need to know what's been done, what's working, and what is not working. We need to be able to give these details in a way that the veterinarian understands it, gains their confidence, validates your work as a technician so that you can get results. We also want to, like I said, administer preemptive medication. If you think it's something that would hurt you, it's going to hurt them. And we want to go back and reevaluate. How are we doing with our pain relief? Do we need to increase it, decrease it, modify it in any way? Reevaluate the patient. Sound pain management anticipates or predicts pain before it occurs. Signs in some pets do not appear until we have severe pain, and by then it's often too late. Pain tolerance will vary widely. Some animals will hide pain, like we're showing pain in a feral or wild environment, they would get picked off pretty easily. Beagles, not so concerned. Typically this breed is pretty sensitive, and it's not a bad thing, just they definitely feel their pain. We want to treat patients without requiring proof. There are going to be Labradors that walk in with an arrow sticking out of their side and they're wagging their tail. They're painful. They don't have to tell us they're painful. We know they're painful, and we should acknowledge that. We can tailor our analgesic protocol to the individual. So we want to keep them out of pain. We want to anticipate pain. We want to make sure that if it is painful or we think that it should be painful, that we are acknowledging that and keeping them out of that level of pain. And then we're just going to have to develop our experience, and that will help us establish our expectations for each animal. But again, you've got to be able to diagnose pain. What does it look like? What does it look like in different species? This is a pain face in a horse. If you're not a horse person, you might look at this drawing and go, well, it looks like a horse to me. But we're seeing lowered ears and the increased distance between the ears at the base. They're spread out. The muscle above the eye is contracted. They've got more of a tense stare. Their nostril is dilated out in this medial to lateral direction from the midline just to the outside. Their muzzle is flattened and their lips are pressed together, and they've got tension in their facial muscles. If you can't recognize that, you just need to watch more horses. We have to be familiar with that species. We have to be familiar with breeds. Like I said, a beagle may respond differently than a Labrador, and we have to know the individual, and this often comes from the client. They won't necessarily say that their animal is in pain, but what they might say is that animal is acting differently than they usually do. We also need to know what surgery are we doing, what illness is this animal experiencing, because that will tell us how painful it can be. So we need to recognize physiologic pain versus behavioral pain. Behavioral pain will be different for different species. Looking at their posture and using our visual analog scale. We also have to take into account that they may be experiencing dysphoria, which is it's not really pain. It's a feeling of disconnectedness between the brain and the body that's a little bit scary. And so that's more of an anxiety issue that we need to address in a different way. Pain is bad. Pain is bad. It is the fifth vital sign that we should be checking after we check our TPR, that's 3, and our CRT mucous membranes, which is blood flow through the body, that's 4. Okay, and then 5th, we're going to check pain. Okay, that should be something that we normally check every single time. Okay. When we have pain in the body, we have increased cortisol levels. This is a stress hormone. We also have increased cardiovascular stress. If you look at our wound lecture, we know that cortisol levels delay healing. So what does pain do? It delays healing. So how does pain work? Well, first, we have nociception. Nociception is the receiving of information from nerve cells that there is a painful stimulus. So nociception is recognizing a painful stimulus. The noci part of this comes from noxious stimulus. From that recognition, so the recognition happens from this noxious stimulus, which can be mechanical, chemical, or thermal, and it is turned into an electrical stimulation that will travel up the nerve. This is called transduction. So we we get burned from a hot stove, and that information, the thermal information, is turned into a nerve signal. That's called transduction. That nerve signal is transmitted up to the spinal cord. That is transmission. At the spinal cord, we have modulation. There are two things that happen at the spinal cord. One, the information will get projected up to the brain. The second is in this little space here, there is a little interneuron that's going to transmit that information to the motor neuron that's going to move the leg. That's called a spinal reflex. So you're either going to get a spinal reflex, well, you're going to get both. Okay, you're going to get a spinal reflex, which is going to move your hand away from the hot stove. That's going to happen pretty quickly because it's all right there. At the same time, now you're getting projection of this stimulus. This nerve is sending information to the brain, and your brain will perceive, ow, my hand just got burned. What happens first, though? You move your hand, right? And then you look at your hand and go, oh, I'm burned, okay? Because this happens secondarily to that spinal reflex. This is very quick. So in order to disrupt the feeling of that pain, we can disrupt it here by not touching the stove and not creating the transduction, or if the nerves were blocked right there with a lidocaine, we wouldn't feel it. Transmission, so we can block it, block the sensory nerve coming up into the spine. We can block it at the modulation site or the projection site so that the spine is deadened and we don't get the information up to the brain, or we can block it at the site of the perception. Okay, so there are 4 places that we can actually block it. And any good pain management is going to interrupt nociception at one of those 4 places: transduction, transmission, modulation, or perception. You should know these 4 words and what they mean: transduction, transmission, modulation, perception. That is the pain pathway. Neuropathic pain is different from inflammatory pain. Neuropathic pain is a persistent stabbing, aching, burning, itching, or tingling sensation with or without an observable cause. So neuropathic pain has to do with a nerve pathway. The inflammatory pain stimulating the neuropathic pathway. Okay, so if it is inflammatory and we decrease the inflammation, we're no longer stimulating the neuropathic pathway, and that should relieve some of the pain. Now the issue is that sometimes with the neuropathic pathway, we get what's called a wind-up phenomenon. So the neuropathic pathway, without any inflammation, will act on its own. Let me explain this. In this chart, we see this pain sensation. Okay, it's either this is the feeling. If I were to grade it from 0 to 100% painful, this is what I'm feeling with a pain sensation. This is the stimulus intensity. So something like if you step on a squeaky toy, okay, something soft, it's annoying but innocuous, a squeaky toy, versus if you were to step on something like a spike, okay? And in between here is a Lego, okay? So we all can relate to that a little bit, right? So stepping on something soft, something really spiky and can cause a lot of damage versus a Lego, okay? So it's important that our body listens to the fact that, oh, that's a squeaky toy, I should avoid stepping on it, versus, oh, that's a Lego, I really need to avoid stepping on that, or, oh, that's a spike, I don't want to step on this, this could be a problem. And our body needs to listen to that. Pain is important because if you pay attention to pain, you're going to keep your body safer, right? So what happens if this is a normal pet is we'll step on the Lego, we'll get a little injury, and normally we will feel it at a lower intensity. We won't really feel it all very much. We won't label it as painful if we're stepping on a squeaky toy, but as we go towards the Lego and the spike, pretty painful, okay? If we are feeling our pain a little bit more intensely, then we're going to start to feel pain when we step on a squeaky toy. And the reason for that is that our normal nociceptors, these are nerve endings that are responsible for turning that pain into an electrical stimulus, okay? And they're specific. That's their job. It's a nociceptor. We also have other sensory nerves that are not nociceptors and just feel things. They just tell us where our body is in space and time and what it's feeling at that time. What happens is the nociceptor starts to recruit these sensory nerves because they're all wound up and they feel like they're not getting their information across to the animal. Okay, so this they say, hey, we need a little help. Allodynia, okay, is when normal sensory nerves are now considered nociceptors. They're recruited by the nociceptors to become a nociceptor. Okay, so now we have sensory nerves that are pain nerves. Okay, so now we have a lot more pain nerves available. Well, they're going to feel this innocuous. The animal is going to reach a level of pain that is much higher, hyperalgesia. So they're going to feel that pain at a much higher rate. So if you think about when you go to a doctor and they say, rate your pain from 0 to 10, that's pretty subjective. It's based on your perception of pain, right? But it's going to tell the doctor, are you hyperalgesic or are you having normal pain based on their experience of what you should be feeling. You feel what you feel. There's nothing wrong with telling somebody that you're at a 10 when somebody else would be at a 5. But you have to realize that this is what's happening, okay? We want to try to treat the pain before we get to the point where a squeaky toy is going to cause pain. Okay? Before we get this wind-up phenomenon, we want to keep this pet out of pain, and so that we don't have these nociceptors recruiting sensory nerves. Okay? Part of what we do to do that is to provide environmental and emotional care, put them in a comfortable environment, make them feel safe, give them some familiar elements, make it nice and clean, very comfortable. The next thing we can do is administer analgesia. Okay, so again, we want to try to do preemptively, so before we experience pain. We want to hit it at the transduction point, at the transmission point, at the modulation point, and at the perception point, or at least 2 or 3 of these. So that's multimodal analgesia. The more we can do, the less in terms of dose we need to do for each individual medication, and the more likely we are to get a really good pain relief. We want to match analgesics to the expected pain. So if we know how painful this animal gets, we can either go lightly on pain relief, or we can go a little bit heavier. And we'll talk about what those are, what those choices are. And then we also want to maintain those analgesic levels and keep giving those medications at the right times, and dose it appropriately so they stay out of pain while they're healing. Pain relief should continue at home, and we need to choose things that can be taken at home as well. Our 4 categories are NSAIDs. These are non-steroidal anti-inflammatory drugs. So non-steroidal means they're not steroids, and they're anti-inflammatory. Local anesthetics like lidocaine can help block the nerve transmission. Opioids are very helpful with pain relief because they affect receptors in our brain and body, which produces natural pain relief. Alpha-2 agonists do similar things. There are some other new classes of drugs that we use to antagonists. The neuromuscular junction between the nerves and the perception of the nerves, it puts a block right there. So things that keep the pain sensation from being perceived. And then also anticonvulsants like phenobarb or gabapentin deaden those nerve endings, keep those synapses calm, and keep things from being passed along. So we want to anticipate and monitor pain. With NSAIDs, these are going to modify the inflammatory response, so it decreases the inflammation, which is not going to irritate the nerves. It's therapeutic, and we can use this as a pre-treatment to reduce intraoperative pain and postoperative pain. We have some common NSAIDs that we use. I'm just going to say one of them right now is Rimadyl. Okay, I'm just saying these words so that you can recognize them later. Onsior. Okay, they are things that are going to block the effectiveness of prostaglandins. Okay, prostaglandins are pretty potent inflammatory modulators, and these are going to block prostaglandins, which are normal things in your body. All right, so we do have to be careful with NSAIDs. They can cause GI upset in dogs and renal disease in cats, and cats are particularly very susceptible to NSAIDs, so we have to be very, very careful when we give it to them. But it is something we typically will give the owner to give at home. Some anesthetics that we can use, both local and regional. We will, for local, we just infuse around the skin, just get those nerve endings in the skin and the dermis. If we're doing a regional block, we're blocking a whole region. Feed the whole region. For instance, this is a circumferential ring block that we would use in a declaw. So if we want to block all of these nerves that feed these claws, we're going to block at the level around here to deaden these nerves. Cats and goats are very sensitive to lidocaine, so we need to use lower doses because we can see a toxicity in cats and goats. We can see it in other animals as well, so doses are very important. One thing I'll say about epinephrine, this is often found in local anesthetics like lidocaine. The reason that it is that epinephrine will vasoconstrict or shut down the blood vessels a little bit to this area, which will actually keep this drug in this area for longer. So it prolongs the action of the local and regional anesthetics. We can apply this topically, infiltrate it, or do this circumferential ring block specifically. This is one thing that we do in dental medicine. If we're going to need to do some surgery or dental extractions here, there are nerves that come out of the skull right here at the sub or infraorbital foramen, and also down here at the mental foramen. And these nerves supply this area of the bone and tooth roots. So if we can block here, we can keep the animal from feeling along here. And so that's a very common nerve block that we use. We can use it in the joint as well. So we can block the whole joint, make that joint feel better if they're having joint pain. We can use it in the pleural space, which is inside the thorax, if we're needing to place a drain in the thorax, or make it easier for an animal to breathe if it's painful to breathe. We can put it in the spinal column, outside the spinal cord. If we can do it and deaden the nerves of the spinal cord with fluid. Because remember, there's cerebrospinal fluid around the spinal cord. So if we put lidocaine into that cerebrospinal fluid, that will kind of deaden a certain amount of the spinal cord and block the transmission up to the brain, and also sometimes those spinal reflexes as well. We can also give it IV, and we give it IV to deaden the nerves in the heart and get the heart to beat more regularly. Opioids affect normal receptors in your body. There are mu, kappa, sigma, and there's also delta receptors. This is the Greek symbol for delta. These receptors normally receive natural endorphins, and so you can produce your own natural opioids in your body by doing things like exercising. If you're doing something for yourself, like rewarding yourself for doing your homework, that releases natural endorphins as well in your body. So you can actually create in yourself a feeling of well-being and pain-free environment within yourself by changing some of your behaviors, which is pretty cool. But we do have these receptors that are susceptible to receiving opioids, which can be dangerous because they are a natural receptor, and so our body likes to receive these natural opioids, natural endorphins, and so if there's a way to synthetically do it, we will take that as well. So that's why people are a little bit more likely to have addictions like heroin addiction, morphine, pain relief addictions. We classify them as agonists, antagonists, mixed agonist antagonist, and partial agonist. And this partial agonist is a agonist antagonist as well. Okay, so what does that mean? Well, an agonist is something that is used to directly affect the cell, much like a natural endorphin would do. So if we have a receptor on a cell, this opioid agonist, especially if it's a pure opioid agonist, is going to look just like a natural endorphin, and it's going to fit like a puzzle piece into the receptor. So it's going to create +1 or 10 times the effect that the natural endorphin would do. Okay, so like morphine is 1 to 2 times the natural endorphin. Hydromorphone is like 10 times the natural endorphin, and fentanyl is like 100 times the natural endorphin. So whatever that natural endorphin, however that would make you feel, taking away pain, making you feel good, these do it better. Okay, and those are called agonists because they fit, the puzzle pieces fit together very well. So we were going to use those to treat severe pain. For moderate to severe pain, we're going to use a partial mu agonist. So this is a mu receptor. Okay, buprenorphine will fit into a mu receptor but only partially. Okay, so it's not going to have as big of an effect, maybe a plus or minus, not as big as morphine, okay, because it only has a partial effect. It does also have some antagonist properties, okay, so what it can do is it can kick out this pure opioid agonist if we give it after we give one of these, and then just have a partial effect. So we can kick this out, get rid of the pure agonist, and just have a partial effect. This mixed agonist-antagonist has an effect on the mu receptors as an antagonist, so it will come in shaped like this. But on the kappa receptors look a little bit different. They might look more like this. Okay. Kappa receptors are not as effective, so they look more like this, so this one will fit in a little bit better and create the kappa response, which is a little bit less than the mu response. Okay, so this mixed agonist-antagonist doesn't fit well into the mu receptor, fits better into the kappa receptor, but it fits well enough into the mu receptor that it will kick these guys out, okay, and block them from going in. So it does work as an antagonist, meaning it will block that receptor. Okay. Opioid reversal has to do with antagonists. These are things that completely block and kick out things from that mu agonist. Okay, so if we have morphine coming in, and then we need, and it's attached here, we can kick it out by bringing in naloxone or butorphanol tartrate, and that will take the place of that and have a negative effect on the cell, so you will not see that. One other synthetic opioid, I don't find this as effective for pain relief, but this is called tramadol, and this is something that was synthesized within a lab. Alpha-2 agonists. These guys work because it's an agonist. It's going to work on natural receptors in the cell, not opioid receptors, but alpha-2 receptors. Alpha-2 receptors work in the sympathetic nervous system, and they have very specific things that they do to the sympathetic nervous system. Some examples would be Domitor, dexdomitor, and xylazine. These inhibit norepinephrine. Okay, so they're going to kick norepinephrine, which is a stress hormone that causes you to go into the fight or flight response. And these guys are going to come in here and kick out that norepinephrine, and then cause relaxation, cause a little sedation, cause some analgesia. Okay, so we do commonly use these. If we need to keep the animal on medication for a long period of time, and we have to redose these things frequently, what we can do is just hook them up to some fluids. So place an IV catheter, hook it up to some fluids, and put the medication directly into the bag at a certain rate, so they're getting some pulse doses of this medication over time. Very common for us to use morphine and ketamine together in a drip. If it's not a cat, we'll add lidocaine as well, and that creates a really good steady state of pain relief. We can also use an alpha-2 agonist, dexmedetomidine as well. Ketamine is an NMDA medication that is a dissociative, which by saying dissociative, I mean that this brain and the spinal cord are disassociated. So whatever they're feeling in the body, they're not perceiving it in the brain. So this is ketamine. It's an NMDA receptor antagonist. We can also use gabapentin as an adjunctive analgesia. We can use tranquilizers to deaden the perception, corticosteroids to reduce the inflammation and decrease histamine release, and then tricyclic antidepressants also work to modulate the response to pain as well. Some non-pharmacologic treatments that we can use: heat, massage, therapeutic exercise, aquatic therapy, electrical stimulation, acupuncture, you've heard all this before, therapeutic ultrasound, extracorporeal shockwave therapy, and then cold laser therapy or low-level laser therapy. In large animals, there's some differences, and I want to go through those differences primarily. Now, we don't tend to use as many pain relief in large animals, specifically food animals, because if we're going to use them as food, then if any medication that we give them could limit our use for their food, their milk, or their meat. But we do have to remember that if they're painful, we need to control that. If we're going to keep this animal, let's control the pain. We can use the same rules, preemptive, multimodal, and giving analgesia over time. That's all going to help. With all large and small animals, NSAIDs can work as an anti-inflammatory and an analgesic. Opioids help with moderate to severe pain. We can use butorphanol, morphine, buprenorphine, and fentanyl. We have to remember that in both cats and horses, opioids can cause excitement. It's dose dependent, so the higher you go, the more excited the animal will get. Alpha-2 agonists are common in large animals, and so we use xylazine a lot, especially with horses. We have to use very low doses with cows, but xylazine in horses is pretty common. Local anesthetics, we can use lidocaine as a constant rate infusion. We can use mepivacaine or bupivacaine to put into the joints or to put into wounds or around wounds so that we can do whatever we need to clean and suture those wounds. We often use protective agents with these guys, so we'll supplement them with nutraceuticals or cartilage, building blocks of cartilage to help them rebuild cartilage in their joints. We can use ketamine and antispasmodic agents like we do in small animals. And basically, we just need to take care of them really well. This is what good husbandry means. Keep their stall clean, keep them on nice soft bedding, feed them well. Horses are treated as companion animals. Their performance is affected by pain. They can become very violent or dangerous if they're in acute pain, so we have to watch that. Owners are more likely to spend money on their care than on food animals. So we'll be giving these guys non-steroidal anti-inflammatories, opioids, other agents, CRIs. We're going to spend some money on the horses. With cattle, sheep, and goats, these are ruminants. The reason that this is important to consider is the first stomach that we put anything into, food or pills or tablets, is the rumen. Hours, a couple of days, a couple of years for this pill to get out of the rumen, get chewed back up in the stomach, and the cud comes to the omasum and then to the abomasum. Okay, so how long is it taking to get from the rumen through into the places where it's going to be absorbed into the bloodstream? We don't know. So giving them something orally is not going to be very helpful. We also have to consider the economically to treat this animal. We have to consider drug residues in the meat and milk, and like I said, ruminants and oral drugs just don't mix. We do use the same drug classes as we use in horses. Camelids, alpacas, and llamas are more likely to receive analgesics than cattle, sheep, and goats. Remember, we don't typically use them for milk or meat. They're often more companion animals. We do have to take into consideration that they have a similar GI tract as to ruminants. They have 3 compartments, but their first compartment looks like the rumen and acts like the rumen. So they have 1, 2, 3. The esophagus, the small and large intestine, but that's basically what it looks like. But we can use the same drug classes as in ruminants. Pigs have an absolute economic value. Often it's just a better idea to slaughter pigs than to keep them out of pain unless they're a pet or a very valuable breeding animal. Same drug classes as ruminants for these guys as well. That's what I have for pain relief. It's actually pretty basic. We get more into the medications that we can use in pain relief and some different things we can do with pain relief. But this is a good time to start talking about it because I want you to be very aware of your own pets, the pets that you see in practice, and start to recognize those signs of pain earlier and earlier and earlier and earlier.